So I promise I'll be on time, so don't worry. So today we are here discussing about a very interesting and frequently overlooked topic, which is drug allergy. Drug allergy is a very broad part of allergy, difficult many times with a lot of consequences on our patients' healthcare access during their entire life. So especially in pediatrics, this can be particularly important, proper management and identification of these patients since this age. So the title of the talk was given like as the truth and misconception, which is a very broad and wide topic. So talking about drug allergy in general would be impossible in this time. We'll just try to give some introduction to this and what I believe is some of the truth and the main misconception we might have. So drug allergy, as far as we know, the truth is that drug allergy is an adverse drug reaction that basically results from the stimulation of the immune system. So what is an adverse drug reaction? It's any unwanted and detrimental reaction to a medication. And adverse drug reaction is a broad category that is now divided into two types, type A and type B. So type A are due to the pharmacologic activity of the drug and are far more common than type B, which are the drug hypersensitivity reaction. What we usually call allergy is a drug hypersensitivity reaction with an immune mechanism. And there is formation of new antigen with the drug, recognition by the immune system, and several clinical manifestations that what we usually call drug allergy. There is the PI phenomenon in which there is a direct stimulation of the drug on the immune system receptor. So not recognition, but direct stimulation. And there are the pseudo-allergic reaction in which there is pharmacological activity, metabolic activity of the medication on the recipient's cells. So type A are largely predictable and dose dependent. So just imagine the drowsiness you might get when you take old generation antihistamine, okay? Or abdominal discomfort with NSAIDs. Type B reaction, on contrary, are largely unpredictable and most of them dose independent or not with a linear correlation with the dose. So type B reaction, the drug hypersensitivity are those with typical manifestation of allergy, okay? So we saw before PI, pseudo-allergy and allergy. Why drug allergy? There is involvement of the immune system. So here, it's a nice, you will probably recognize the graphics of the New England Journal of Medicine. So this is adapted from a very nice paper on penicillin allergy by Mariana Castells, and shows you the Jellincomb's classification of the hypersensitivity reaction. So these three are the antibody-mediated reaction. First one is the classic immediate hypersensitivity. So immediate hypersensitivity is what we broadly call like commonly allergy, okay? So it's there is a recognition of the drug that works as an aptan on the innate immune system cells, the dendritic cells. The antigen is processed and presented to our naive T cells. There is a skew, like a polarization to a Th2 phenotypes, isotype switching of B cell producing Ig that recognize our drug and cross-link on the surface of mast cells, inducing the granulation and mediator release, okay? This will bring to urticaria, angioedema, bronchospasm, anaphylaxis, classic type 1 manifestation. Type 2 are the cytotoxic reaction. So the antibody involved is frequently an IgG. There is direct recognition and toxicity and the damage mediated by the antibody and activation of the macrocytic lineage. So for example, hemolytic anemia is one of these, drug-induced thrombocytopenia, and the hemorrhagic petechia. Type 3 is when the damage is caused by immune complex deposition, most of the time on the blood vessel walls or on the kidneys. there is activation of the complement and the activation of the neutrophils that damage the tissue by releasing of their mediators. So classic things, serum sickness, arthus reaction, very rare now to find, small vessel vasculitis. So those were antibody mediated. Then we have all the broad topic of the cell mediated hypersensitivity, which is allergy, technically speaking, with a different form, not so commonly recognized by non-allergist physician. So the T cell mediated reaction are like divided further into other 4 types. What is important for us today are the type 4B, C, and D. 4B is there is an eosinophil recruitment and activation. So fever, lymphadenopathy, the classic DRESS we'll see later on. The type 4C, there is direct damage on the keratinocyte caused by granzyme release, perforin, and other toxic enzyme. And the type 4D, there is, again, a neutrophilic activation by T cells in which we have these form of delayed reaction. So T cell mediated reaction are delayed, are not immediate. It takes time for the T cell to start the reaction. So we can divide the drug allergy also by timing. So we see here early immediate reaction, usually less than an hour, depends on the way of administration of the medicine. So if it is oral, it might take a little bit longer, up to 1 hour, 1 hour and a half, usually very unlikely later. And the delayed non-immediate reaction that can take place from 6 to 8 to several days after the exposure to the medication. So what is important for drug allergy in children? Of course, as you can imagine, drug allergy in children is less frequent, less common than in adults. Why? They are exposed to less medication. That's a very easy explanation. Their immune system is still immature. The perception of drug allergy might be different to real drug allergy. So only 5% of these adverse drug reaction that we've seen as a broad term are actually classified as drug allergy after medical evaluation. Parent perception may influence a lot. And in this country practicing, it's sometimes kind of a nightmare with the terminology. So the word asasia, which we translate as allergy, it's used many times to refer to any kind of disease from like itching of the nose to a small spot on the skin to a life-threatening reaction like in the OR. So the difference in drug allergy perception versus real drug allergy is striking. So these are 2 studies, one in Korea, one in Turkey, in which you see the reported drug allergy by parents and the real drug allergy after medical evaluation. So in Turkey was striking the difference, okay? So which drugs? We see here. So depends a lot on the type of exposure, on the subpopulation that we are considering. Most of the time, which are the drugs our children are exposed to most frequently? Antibiotics, NSAIDs, painkiller, antipyretics, some groups, anti-epileptic drugs, which do have a high, let's say, allergic potential. And which are the manifestation, the clinical features? Depend a little bit also on the class of medication. So some of them tends to give more frequently a type of manifestation. For example, like urticaria angioedema is more frequent with beta-lactamics and NSAIDs, while the scars, so the severe cutaneous adverse reaction, are more common with, for example, anti-epileptic drugs. But we do see here that beta-lactams antibiotic are very frequently involved in several type of different reaction. And the second, more frequent, are the NSAIDs. So classic type 1 hypersensitivity, urticaria and angioedema, very frequent in children, as you know, probably much better than me. Yeah, it can be a drug allergy. Yes, definitely it can be, but most of the time actually it's not. We know that urticaria angioedema is frequently encountered during infection in these age groups. So patient might have an infection, develop urticaria angioedema because of the infection, but is prescribed also an antibiotic, and then the it's very easily misattributed to the antibiotic, the reaction. So we see usually angioedema may involve the face, the lips in particular. Urticaria can affect different parts of the body. It's always important when I do see an urticaria, always asking a few questions. So to classify it as a normal classic urticaria. So what are the lesions? So usually lesions of urticaria are hives. So they are raised, usually light pink. They are pruritic and not painful. They are transient. Very rarely, a single lesion of urticaria will keep the same place and same shape for longer than 24 hours, usually much less. And it subsides without leaving scars, marks, or bruises on the skin. So the next type of reaction is a maculopapular rash. Morbilliform eruption is the most common type of immune-mediated drug reaction. So the rash can affect different parts of the body. Usually it's less severe on the face. There are maculopapules, sometimes confluent with variable size, usually maximum within 2 weeks, but can be faster when the patient is re-exposed to the same drug. And it has a very benign prognosis. So usually it tends to subside spontaneously upon discontinuation of the medication. Can desquamate a little bit, and sometimes, yes, it can be very difficult to differentiate by a viral rash. So let's go into things a little bit more complicated. So among the severe drug hypersensitivity reaction, not immediate, so delayed, there is the DRESS. So the drug reaction with eosinophilia and systemic symptoms. It starts usually with a maculopapular rash. So at the very beginning, the very first stages can be difficult to differentiate by a benign maculopapular rash, but these patients are sick. So they have nodes enlargement, they have fever, the rash can become confluent and with big patches of involved skin. We have to do blood tests in this patient because we might have support to the diagnosis. So leukocytosis, eosinophilia might be present. On this smear, you can find atypical lymphocytes. There is liver injury, and there is a very interesting phenomenon, which is the reactivation of herpes viruses, which is thought to be caused by the stimulation of lymphocytes. So they do expand and they do release the dormant herpes viruses. And this might be part then of the clinical phenotype. So this is very important to recognize. This patient needs have a prognosis which is severe many times, if not adequately treated. Which drugs are causing DRESS in children? So we see that the most frequently involved drugs are the aromatic type of antiepileptic drugs, okay? Much more frequent. This is a retrospective analysis of several different reported cases. With many of these, the quality of the data is very low, so don't expect to have nice data collection. So these are different type of case reports that are grouped together. We see that even with like large exposure paracetamol, like just imagine how many exposure we have in our patients, is a very rare cause of DRESS, okay? While the antiepileptic are much more common. So let's moving on. So when we have involvement of the neutrophils, what we get can be this type of disease. So acute generalized exanthematous pustulosis is a very rare reaction, but quite strikingly peculiar. So there is a diffuse pustulosis. Usually you have this crop of sterile pustules that involves mostly the flexural areas and the back. So you see here, there is a collection of sterile material. This patient may be mildly sick, they might have fever, but if it's recognized as a drug reaction and the drug is stopped, usually the prognosis is good, okay? We have most of the time antibiotic causing this, but it's also possible to have antiepileptic medication. So Steven Johnson and toxic epidermal necrolysis is another very severe type of reaction. Usually starts again with a diffuse maculopapular exanthema. So the very early stage, it's difficult to differentiate this reaction, but this patient quickly progressed to have a very severe phenotype. There is frequently a mucosal involvement, which is usually something that can help a lot in identifying these two diseases. Fever is often present. So they are basically the different spectrum of the same problem. So we call it Stevens-Johnson syndrome when the involvement on the skin is less than 10%, and toxic epidermal necrolysis when the involvement is more than 30% of the skin. And there is, of course, this overlap. Prognosis is slightly different, but the mortality is very significant, okay? So, as we see, mucosal involvement can be prominent and can have, in those who recover, a very long prognosis. So ocular complication can persist for months and years after the reaction. So you see the involvement of the conjunctival and of the lips and the oral mucosa. And these patients can have detachment of large part of the skin. So they are basically cared in intensive care unit or in burn unit. So the supportive care is very important. So after we saw the truth, let's see a little bit of misconception. And I picked up two of the most common type of allergies in kids and try to find what can be a wrong conception. So penicillin allergy is quite frequent, okay, compared to other. Why? Because it's basically one of the most or the most prescribed antibiotic, especially in children. So 90% of our patients with a documented penicillin allergy, and the classic thing is the label on the electronic medical chart that can be there since forever in our adult patient, most of the time since childhood, are actually not truly allergic. Penicillin allergy in the general population is rare, of course, as it's present only in 1% of the general population, but in certain places, in certain areas, can be reported by up to 10% of people, for example, attending to the emergency department. One important thing to remember is that penicillin allergy is not lifelong. So 50% can lose their reactivity after as short as 5 years. So what are the consequences of labeling our patient as penicillin or beta-lactamic allergic? So there is a frequent use of second-line drugs, second line in combination to obtain the same coverage of a penicillin. This leads to a higher rates of hospital-acquired antibiotic-associated infections, so Clostridium and MRSA or vancomycin-resistant enterococcal infection. And there is this, like shown in several studies, an increased risk of surgical site infection because the patient are receiving antibiotics which are not considered the first choice. And this is usually it's my secret weapon when I talk to direction of hospital and about this thing. There is a much higher cost induced by treatment with non-first line antibiotic. That has been estimated up to 65 to 1. Okay, we know in our pediatric patient, beta-lactam allergy is the most commonly found, but the prevalence in pediatric can be up to 10%. So the classic thing, what are your allergy? Oh, I'm allergic to penicillin. But only a small amount of this is confirmed through testing. There is a big discrepancy. This is misinterpretation of symptoms, misinterpretation of type of symptoms which are frequently not allergic. And when we see the real risk of anaphylaxis is extremely low. So 0.015 to even less per treatment course. And for cephalosporin, it's even lower. So what to remember? Avoid labeling our patient as allergic to penicillin without proper allergy assessment. The label that we are applying to this patient will stay with him for his entire life until they meet an allergist with an interest in drug allergy that can start the labeling process. And always remember that this is not a lifetime verdict sentence. This is basically something that needs to be reassessed over time, okay? Because this might be lost over the years. So what to do? Hypersensitivity reaction to a beta-lactam. So if it is an immediate type, we have specific IgEs that can be ordered We have skin prick test, which is pretty standardized for this group of medication, and we have intradermal reaction. After this thing, we can decide to proceed for challenge with the culprit drug if we want to exclude the presence of allergy, or with an alternative medication if the allergy is confirmed and we want to find a safe alternative medication, for example, among the cephalosporin. For the delayed, the type of test is different, but the procedure is pretty much the same. So the second most common is NSAID allergy. Why is a misconception? So NSAIDs, we know, are largely used in all age groups from infant to children and adults. Worldwide, millions of people are exposed because these medications are frequently available over the counter. And older kids can be, apart from paracetamol and ibuprofen, can be exposed to many other molecules. So the prevalence of drug adverse reaction is 0.6 to 5.7 in the general population, but the exact number in kids is not really well reported. Old data, very old data from the 80s, shows that there is a prevalence of aspirin intolerance in children up to 0.3%. And in asthmatic children, the prevalence of NSAIDs hypersensitivity is 0.9%. In some studies, especially in severe reaction, NSAID can be more frequent than beta-lactamic reaction. So this is the interesting part. What we call NSAID allergy most of the time is not allergy. What does it mean? It's not an immune-mediated hypersensitivity reaction. What happens is that there is an alteration of the metabolic pathways of the arachidonic acid that is caused by the pharmacologic action of this drug on cyclooxygenase 1. So these patients, to the cross-reactor, it's useless to change an NSAID. So if they reacted to ibuprofen, they're going to react to diclofenac. They're going to react to ketoprofen in the same way. So here is what happened, basically. Inhibition of the cyclooxygenase basically shift the arachidonic acid metabolism on this side. So with generation of leukotrienes, which in turns cause bronchial constriction, vasoconstriction, increase permeability, there are mucosal hypersecretion and neutrophil activation. And we lose basically the inhibitor activity of the prostaglandin on the histamine release. So there is also an increased histamine release. This causes the clinical manifestation of the NSAID hypersensitivity. Last slides, and then I close. So this is a general thing to remember always when we talk about NSAID hypersensitivity. Our patient can be single reactors, which is much rarer, or cross-reactive. So cross-reactive can be divided further into those who have a respiratory exacerbated airway disease. Okay, so most of these have asthma or rhinosinusitis, or they have an exacerbation of their chronic cutaneous disease, most of them chronic urticaria and angioedema, or they can have a de novo appearance of urticaria and angioedema. So these are cross-reactors. So any kind of exposure to a COX-1 inhibitor can trigger this type of things. The single reactor is thought to be IgE mediated, but it's much rarer and can cause the classic allergic manifestation of immediate or delayed type. Okay? So a final truth after the misconception, you always use a pragmatic approach. So when there is a suspect case of allergy, go through a detailed medical history, try to get more information as possible. Refer to the allergy for diagnostic evaluation, skin test, in vitro, in some cases available, in another not, and the gold standard, which is a drug provocation test. Is it confirmed the hypersensitivity? Then the avoidance. So don't skip this thing, because this label can have ominous consequences later on in life. So always, this is my final message. In medicine, truth is an evolving concept, okay? So don't get too attached to what is truth now, because this might not be true tomorrow. Thank you very much for your attention.
Dr. Salvo, thank you I think that was about the most clear and understandable presentation of both the truths and the misconceptions of drug allergies that I've ever heard. So thank you. We're waiting for more questions to come in from the online group. Feel free to those 1,000 of you that are signed in already this morning online to send in some questions for us. While we're waiting for those questions, we live in a very multicultural, multilinguistic society. And our patients don't always differentiate between allergy, intolerance, reaction, and hypersensitivity. what words do you use and how do you explain this to a patient that you think it's an allergy because all your friends call it an allergy, but it's not an allergy?
That's a very good point. And thank you, Dr. Fisher, for asking. And to be honest, it's not only patients. So most of the time we see also from other physicians, patient labeled as allergic when actually they are not. So what I try to explain to my patient is that allergy basically requires the immune system involvement. So it's your immune system that is fighting against the medication, okay? If there is no fighting, if there is no immune system activation, this can be largely predicted. It doesn't, for example, mean that you have to avoid it your entire life. You might like look for similar medication with a better safety profile. You can take other medicine to prevent side effects, so like gastrointestinal side effects. So this is very important for the management later on. While if they are really allergic, and what is more difficult here is making them understand that it is very important to know what you're allergic to and to bring like papers, okay? Most of the time I see patient who comes to my clinic, they tell me, okay, I did a surgery. They told me I was dying, but they didn't tell me which medication I took. And they refused to give me the medical documentation. And for an allergist, that's just a nightmare. So we don't know anything. What is important in understanding that knowing your allergy is crucial, okay?
Thank you very much. Thank you. And then a question from Dr. Priscilla online. So a child taking antibiotic with sudden appearance of rashes can continue the antibiotic?
It depends, of course. It's a case-by-case basis. So it depends how sick is your patient, what are his baseline characteristics. And for example, always remember, so prescribe antibiotic when they are needed, okay? The classic thing is with EBV infection and the aminopenicillin. So we know now that exposure to aminopenicillin in a patient with an EBV infection can induce a maculopapular rash, which is not allergic. So the patient can take the same antibiotic the next month once he cleared the infection and not having anything. So before we prescribe something, just be sure we are treating a bacterial infection in this case, and then consider like the risk of continuing the medication or shifting to another one. Or, for example, you can decide to stop that medicine, complete the course with something else, and then refer for evaluation to see if that thing is something that was a real allergic hypersensitivity, immune-mediated reaction or not.
And briefly,